Thank you very much for those kind words of introduction. And I'm delighted to be able to present to you and then have time for discussion. As usual, I put in more slides than I may be able to get through. I've got a lot to share, but we'll see. I'll do my best. And then, but make sure that we have time for discussion. These are my disclosures. These are all companies that I help with clinical trial design and conduct and publication. And then there are, in the bottom of this slide are a number of organizations with which I participate doing research and education. This is where I work. This is the Providence, Swedish medical complex in downtown Seattle. And we're looking west toward China. That's the Puget Sound, and then covered by clouds, of course, are the Olympic Mountains. Seattle is ringed by snow-covered mountains, so it's really quite a beautiful city. I like to start any talk on psoriatic arthritis with this slide, which gets across the point that it's a very complex disease with multiple clinical domains: skin, nails, arthritis, enthesitis, spondylitis, but also, importantly, associated conditions such as uveitis, inflammatory bowel disease, and very difficult are the genetically driven features of obesity, cardiovascular disease, which is represented by this photograph of this woman in the lower right-hand corner. And I'm going to come to the issue of obesity later on. These are the various clinical domains that we focus on primarily when we see a patient in the clinic. This well depicts what you well know. The patient may have peripheral arthritis, enthesitis, dactylitis, which is swelling of a whole digit and includes arthritis, enthesitis, and osteitis, spine disease, which may involve the sacroiliac joints and spine, or may just involve the spine. This awful, terrible skin disease that's cosmetically difficult and itchy, and nail disease. This is a simple cartoon depicting the nature of the pathophysiology, in which a dendritic cell on the left-hand side of this image is being stimulated by some kind of danger signal, a change in the microbiome of the skin or the gut, for example, or physical trauma, or some other stimulus that leads the cell to produce interleukin-23 and turn on a variety of cells that are involved in the inflammation cascade noted here. And so many of our targets of treatment have to do with this pathophysiology. Each of these clinical domains may have a subtly different cellular and cytokine milieu, as depicted in this cartoon showing synovium, in the enthesitis phenomenon, but also skin and gut. Axial spondyloarthritis is another member of the spondyloarthritis family, along with psoriatic arthritis, only it tends to be more male predominant and is characterized by very severe disease of the spine, in which there is ankylosis across the vertebral bodies and in the sacroiliac joints. Here is a depiction of what might be an evolution of the disease process, in which at first there may be inflammation in the sacroiliac joint region, as noted on the left. Some patients may not have initially disease in the SI joints, but eventually all do. And then later on, there is ankylosis of the joints and the spine. At the current time, there is a distinction between so-called non-radiographic axial SpA, which represents about half of the patients in the US population, and radiographic axial spondyloarthritis, in which you can clearly see changes on X-ray of the SI joints, joint space narrowing, ankylosis, erosions. Now, we don't necessarily see all patients on the non-radiographic side evolving to radiographic. In fact, increasingly we recognize that about half of the patients end up remaining in the non-radiographic group, especially females. In the future, when we move to the coding system known as ICD-11 instead of ICD-10, you'll note that the terms ankylosing spondylitis and non-radiographic axial spondyloarthritis disappear. We no longer are using them, but instead we'll be using this simple phrase axial spondyloarthritis. And this recognizes that it's simply a spectrum from less ankylosis to more ankylosis. Now, one of the key points that we've been learning in recent years is that about 27 to 30% of patients with psoriatic arthritis will have immunologic inflammatory disease of their spine. This is depicted here with this person who has psoriasis lesions on their skin, and then a stiff back from the axial involvement. This happens, as I said, in about 30% of patients. There are differences between axial PsA and axial spondyloarthritis. The axial PsA patients may not endorse all of the elements of the inflammatory back pain criteria noted here. For example, pain awakening the patient in the middle of the night, or pain that gets better with activity and worse with rest. Only about half the patients with axial PsA will endorse that. Other features include asymmetry of the sacroiliac joint involvement. Sometimes the patient may not have symptoms at all. They tend to have more peripheral arthritis and enthesitis. Here's an example of asymmetric sacroiliitis. As you look at the image on the left-hand side, which is the patient's right sacroiliac joint, there is no involvement at all. Whereas on the left, they have significant involvement with periarticular sclerosis and some degree of ankylosis. The other feature that's intriguing about axial psoriatic arthritis is depicted in the lower part of this X-ray, in which we see these large, chunky syndesmophytes. That's very different than the more marginal syndesmophytes we see in the upper vertebra there and are more characteristic of axial spondyloarthritis. And here again is a contrast between the pure axial spondyloarthritis patient on the right-hand side with multiple levels of ankylosis and sacroiliac changes, whereas on the left, the PsA patients has multiple areas that are involved, but multiple areas that aren't involved, so skip areas. There are also genetic differences between these presentations, HLA-B27 on the right and HLA-B8 on the left. This is important because this distinction, because we're beginning to learn that some treatments that may not be effective in axial spondyloarthritis may actually be effective in axial psoriatic arthritis. We'll come to that later on. Shifting to treatment of these conditions, here is the treatment guidelines that were last published by the GRAPPA group in 2021. And these are, as you can see, segmented into clinical domains. What are the effective therapies in each clinical domain? Peripheral arthritis, spine disease, enthesitis, dactylitis, skin disease, nail disease, IBD, uveitis. And what you see is that most of the treatments that are approved for psoriatic arthritis are effective. The exception is axial disease, where we have fewer choices that we are sure will be effective. The other thing that's notable here is that we don't necessarily suggest one drug over another. I know that it's very common for us to start with methotrexate in psoriatic arthritis, but methotrexate doesn't affect the spine, and it may not be effective adequately in the peripheral joints. So in the US, we move very quickly to biologic therapy, often with a TNF inhibitor initially, but now we are aware that other treatment mechanisms, including interleukin-17 inhibition, JAK inhibition, IL-23 inhibition, can be as efficacious and can be used earlier if the patient desires or the clinician feels that they should because of whatever reason. Here I've specified that the most recent treatment guidelines from GRAPPA do indicate that certain drugs we just don't know yet, including IL-23 and IL-12/23, which are in the midst of study in a major landmark study known as the STAR study with the drug guselkumab. And we also know that CSD-MARDs such as methotrexate do not work in the spine. So here is the list of all of the therapies that are either currently being used in the US or are emerging therapies, starting with what I mentioned earlier, methotrexate, and then going on to the TNF inhibitor class, the IL-12/23 class, the IL-17 class, which is now divided into IL-17A inhibitors and the newer IL-17A and F inhibitors. The currently approved example of the latter is bimekizumab. And there are others in development, including sonelokimab and a very long-acting medication known as ORCA-002. IL-23 inhibitor class is noted. Abatacept can be used, and targeted synthetic therapies, including JAK inhibitors, which we're going to focus on later, TYK2 inhibitors that are just emerging, that are a member of the JAK family, as well as PDE4 inhibitor apremilast. And then one that is a new one to us, which we haven't seen data on yet, is the TL1A inhibitor class of medicines, with tulisokibart being an example. I'm going to touch down on a couple of these more later on. And here are these ones that are newly emerging, and I'm going to include here also the oral IL-23 inhibitor icotrokinra, and one that's in the future, possibly, which is a cell therapy approach in which the TRBV9 positive T lymphocytes are known to be pathogenic in HLA-B27 positive axial spondyloarthritis, may also be effective in HLA-B27 positive psoriatic arthritis patients. And we may be approaching them with deletion of this group of lymphocytes with either a monoclonal antibody or a T-cell engager. Moving to axial spondyloarthritis, these are the most recent ACR, Spondyloarthritis Association of America, and Spartan treatment guidelines for axial SPA published in 2019. I'm part of the working group for the new treatment guidelines that will be emerging very soon. In fact, we'll be hearing more about this in the very near future. In these guidelines, we start with trial of nonsteroidal anti-inflammatory drugs, which can be effective in mild cases. And usually we try at least 2 different nonsteroidals. These CSD-MARDs, such as methotrexate, are not effective for the spine, but sulfasalazine has been shown to be helpful in peripheral manifestations of axial spondyloarthritis. And then we move quickly on to use of the biologic agents, with typically starting with TNF inhibitors and then moving to either an IL-17 inhibitor if the patient has no evidence of inflammatory bowel disease, or a JAK inhibitor. So our choices for treating axial spondyloarthritis are not quite as plentiful as for psoriatic arthritis. And if the patient is getting a benefit, then we in the United States tend to continue these drugs because of the fact that if you do stop them, there's a tendency for the disease to reemerge. And then the guidelines give us some specific guides about some of the specific elements, such as severe hip disease. The EULAR group, along with the ASAS organization, has published more recently an updated guideline, which is very similar to the ACR guidelines. And that is treating very quickly if the nonsteroidals are not adequate with a TNF inhibitor or an IL-17 inhibitor or a JAK inhibitor. They don't necessarily suggest to start with a TNF inhibitor only, since the IL-17 inhibitor can be effective. JAK inhibitors we usually in our country use after a TNF inhibitor, partly because of the safety issues that surfaced from the oral surveillance study with tofacitinib. Of course, if the patient has uveitis, then we will prefer to use a TNF monoclonal antibody because of its effectiveness in uveitis. If the patient has significant psoriasis, then an IL-17 inhibitor may be preferred. And then if the patient happens to have inflammatory bowel disease, then we avoid IL-17s and may use a TNF inhibitor. Now, as mentioned, the treatment options are much slimmer for axial spondyloarthritis. We do encourage patients to be in some form of physical therapy and exercise. We like to use nonsteroidals. And then, as mentioned, are the TNF, IL-17, and JAK inhibitors. But there are a number of treatments classes that are not effective, including IL-6 inhibitors, which are used in rheumatoid arthritis, IL-12/23, IL-23, and PDE4 inhibitors, which are used in psoriatic arthritis. I'd like to highlight, at the request of the sponsors of this program, the data from upadacitinib in both psoriatic arthritis as well as axial spondyloarthritis. Here are the data from the SELECT PsA-1 trial. This is in a group of patients that had not yet experienced biologic treatment. They typically had been treated with methotrexate or sulfasalazine, and that was maintained in the background. Typical psoriatic arthritis patient group. And what we're seeing here is the primary endpoint of ACR20 response. Gray is placebo. Light green is the 15 milligram dose of upadacitinib. The darker green is 30 milligrams, and the burgundy color is, or maroon color, is adalimumab reference arm. And what you can see is that upadacitinib was numerically higher than adalimumab, but at least the point is that it was comparable, with very good ACR20, 50, and 70 responses being depicted here. The other thing that was slightly surprising was how good the skin response was. We're seeing PASI 75 responses in 2/3 of the patients using either dose of upadacitinib, and that was slightly higher than the rates of improvement with adalimumab. And you can also see the higher grades of PASI response noted there. Also, the drug was very effective in resolving enthesitis as measured by the Leeds Enthesitis Index, in which we measure tenderness at the lateral epicondyle near the elbow, the medial condyle of the femur, and the Achilles tendon insertion. And this shows complete resolution in over half of the patients treated with upadacitinib, and dactylitis resolution in over 3/4 of the patients treated with upadacitinib. Based on efficacy and safety data such as shown here, we are just using the 15 milligram dose. And then I'm going to push on beyond this and go to PsA2. This is in a patient population that had been exposed to biologic therapy previously. So if you're using this treatment after a biologic agent, then these are the results that you might expect. Again, very high ACR responses, as noted here. There was not an adalimumab reference arm here, so there's no burgundy colored bar. And then you also see the skin responses, which were very good, PASI 75, 90, and 100, and then resolution of enthesitis and dactylitis. So we can expect a full repertoire of improvement. In these phase 3 psoriatic arthritis trials, it's not typical to try to measure spine disease, and so that was left to the axial spondyloarthritis studies. Before I get to that, I just want to show you one measure, which is known as minimal disease activity, which showed improvement in about 1/4 of the patients where they got to a very low disease state of disease activity state. And then in the safety aspect of the treatment program, the only thing that really stood out was that we had a higher rate of herpes zoster, which is something, as you know, can occur with a JAK inhibitor class of medication. All right, now I'm going to go on to axial spondyloarthritis, and this is the first study, so-called Select Axis 1, in which upadacitinib was used in patients with radiographic axial spondyloarthritis, also known as ankylosing spondylitis. But as we mentioned earlier, this term is going away, and we're just going to end up with the phrase axial spondyloarthritis. Here we're using traditional measures to measure improvement, and that is shown ASAS-40 response in over half the patients at week 14, and partial remission noted in 20%. There was also an improvement in spine scores in this particular study, radiographic spine scores. Now moving on to the phase 3 trial of UPA in the patients who were previously exposed to biologic DMARDs who had radiographic axSpA. We see the improvements as compared to placebo in ASAS-40, which is the primary endpoint, as well as other measures. And in non-radiographic axial spondyloarthritis, which is 58% female in this particular study, most of these patients had either an abnormal MRI of the sacroiliac joints or an increased CRP value, and we can see improvement as noted here. Very similar to what we saw with radiographic axial SpA. So it can be used across the full spectrum of disease. Now, what I was focusing on in those data sets were patients who were relatively early in their disease process. They might have had one in the biologic experienced population. They might have had exposure to, say, one or at most two previous biologics. What about the patients that we are now increasingly seeing in our clinical practice who come in having tried 4 or 5 or 6 biologic or TSD-MARD medications, maybe had a good run with or good experience with each one of them, but eventually lost effect? And unfortunately, that's what we're increasingly seeing in our medical practices. So they're now evolving difficult to treat definitions. And here is the difficult to treat definition for psoriatic arthritis from the GRAPPA group. And we've divided it into two buckets. And I'm going to go to the next slide to really illustrate this. So let's focus on the blue circle. These are patients, up to about 10% of the patients in our practice, who have tried multiple medications, yet have now recurrent evidence of inflammatory disease. They have synovitis that you can see on ultrasound or MRI scan. They have elevated CRPs. They, of course, have tender and swollen joints. They have dactylitis. They have skin disease that is flared. These patients are what we consider truly refractory and are going to need newer treatments to try, or novel practice approaches like using two different biologics, or a biologic and an oral immunomodulatory medicine. And we're increasingly doing that in our practice. In our practice, we have probably 200 patients that are currently receiving dual biologics. You might ask, well, how can patients afford this? Will insurance cover this? In some instances, insurance will cover this for our patients. Usually it's most successful if we have, say, a dermatologist prescribing one of the medications while we rheumatologists prescribe the second one, or a gastroenterologist who may prescribe one of the treatments while we prescribe the other. And we're finding that this can be efficacious. We do have to be cautious about safety, especially infection. We've had some individuals who've run into problems with infection. Then there's this larger green circle, which is so-called complex to manage. These are patients that may have truly refractory disease, thus it's overlapping with the refractory group. They may have a swollen joints and so forth. But they may also have other issues like comorbidities of obesity, depression, sleep apnea, fibromyalgia, osteoarthritis, gout, or be a female gender, all of which make them less likely to respond to a therapeutic approach. Each one of these items that are listed here can lead to that. What if the patient has no swollen joints, their normal CRP, and one of these concomitant problems? Then maybe we shouldn't automatically switch them to a new immunomodulatory medicine, but instead think about other treatments for these particular comorbidities, like use of a GLP-1 receptor agonist, or antidepressants, and so on for the patients with fibromyalgia, or CPAP for sleep apnea, or uric acid improvement in patients with gout. And there's a very similar set of criteria for the axial spondyloarthritis group that was developed by the ASAS Association, and reads very much like what I just went through with you with the GRAPPA definition for psoriatic arthritis. So there are pipeline drugs that could be used, such as sonelokimab is a unique nanobody IL-17A and F inhibitor. The oral agent IL-23 inhibitor icotrokinra, not for axSpA, but for psoriatic arthritis. And then, of course, the TL1A inhibitors and cell therapy targets. So here is a single slide depicting the construct of the sonelokimab molecule. Very interesting. It's derived from a camel or llama immunoglobulin, this VHH region, which is attached to an IL-17A and IL-17F binder, as well as an albumin binder. And this goes across the IL-17A and F spectrum. and it's been shown to be effective in psoriatic arthritis. And at the upcoming EULAR meeting, for which I'm leaving tomorrow in London, there will be a very interesting presentation on a proof of concept of this molecule in axial spondyloarthritis, which showed effectiveness. This is showing the original New England Journal article on the oral IL-23 inhibitor icotrokinra in psoriasis, showing a dose-related phenomenon very similar to the effectiveness of the subcutaneous IL-23 inhibitor. And this is a cartoon depicting the mechanism of TL1A inhibition binding to DR3 on the surface of a number of different immune cells, including T cells, dendritic cells, macrophages, but also, very interestingly, the fibroblast cells. And so this is something which may impact not only inflammation, but also fibrosis, which will be important in many of our diseases, including scleroderma, for example, but also other conditions like inflammatory bowel disease. And then there is one interesting target for cell therapy that has emerged, which is TRBV9 positive T lymphocytes, which are pathogenic in HLA-B27 axSpA. They constitute about 4% of the T cell population in axSpA patients. And depletion of those with a monoclonal antibody, this is an experiment done in Russia and recently published, shows an effectiveness of this monoclonal antibody yielding good ASAS40 responses. There's a T cell engager that is in development for this particular target, which we're going to see future studies with. So we may see cell therapy in these predominantly T cell as opposed to B cell driven diseases. I'd like to just take a couple of minutes to talk about two issues before I close my remarks. And I want to start with the whole area of obesity. Obesity is present in approximately 40% of psoriatic arthritis patients, about 25% of axial spondyloarthritis patients. Obesity plus being overweight is present in about 60% of psoriatic arthritis patients. So they're genetically driven in that direction. So the GLP-1 receptor agonist, GLP-1 is a hormone released in the intestine that has effects in many parts of the body, including the gut, the pancreas, the liver, the brain, all leading to decrease in appetite and other changes in gut motility that end up diminishing our food intake and yielding effective weight loss. It turns out that there are also receptors for this hormone on immune cells, and there's a list of them there. And what we have started to see are interesting translational studies that suggest that there can be a diminution in important inflammatory cytokines such as TNF, IL-6, IL-17, and so on with the use of GLP-1 agonist. Here are examples. There's the weekly injections with either Ozempic or Wegovy, which are both semaglutide, or the newer dual GIP and GLP-1 receptor agonist known as tirzepatide, which goes under the name Zepbound if it's prescribed for weight loss, and Mounjaro if it's prescribed for diabetes. So here's a fascinating trial that was literally just presented in March at the American Academy of Dermatology meeting in the US and published in Arthritis and Rheumatism. And we're going to see this presented again next week at the EULAR meeting. This is a study in which a biologic agent, in this case the IL-17 inhibitor ixekizumab, was used in one arm of the study, And then a combination of ixekizumab and tirzepatide was used in the other arm of the study. Let's look at the results. So here we see the results of the primary endpoint, which was ACR 50 response along with a 10% weight reduction. Not a surprise, clearly more in the treatment arm, the combination treatment arm, than in the ixekizumab alone arm. If we look over at the ACR 50 response, very interestingly, there was a statistically superior improvement in the combination arm of this more joint-specific outcome measure, not including weight reduction as part of the outcome. And one of the interesting things is we started to see separation of the two different arms at 4 weeks before there was any meaningful weight loss. So this raises the question, does this medication serve an immunomodulatory purpose as well as a weight loss purpose? So clearly, if we reduce the number of fat cells, especially visceral fat cells, that are producing an inflammatory molecule, adipokines, such as leptin, then we might expect an anti-inflammatory or immunomodulatory benefit. And so we are increasingly seeing patients who are on this combination of treatment, a biologic on the one hand, and then a GLP-1 receptor agonist on the other, whether it's tirzepatide or semaglutide, and whether it's TNF inhibitor or JAK inhibitor, et cetera. And we're seeing and hearing patients in our practice that are improving. And so this is like, if you will, a dual or combination therapy. I'd like to end with just one cautionary comment, and that's about the whole issue of fibromyalgia. And I know for you, fibromyalgia is a difficult subject. The patients are painful, they're fatigued, they take time emotionally to deal with, but they have a real condition. This is now termed a nociplastic pain, according to the International Association for the Study of Pain. Nociplastic pain, the third bullet down, is pain that arises from altered nociception despite no clear evidence for disease or lesion of the somatic system causing the pain. That's different than nociceptive pain, where the patient has clear-cut inflammation in a swollen joint, for example, or clear-cut inflammation in the sacroiliac joints causing back pain. That's nociceptive pain, and that's our traditional way of thinking about pain. But there are these two other types, nociplastic as well as neuropathic pain. An example of neuropathic pain would be diabetic neuropathy, or an impingement condition, say at the carpal tunnel. This is caused by pain caused by a lesion or disease of the somatosensory nervous system. So we need to be increasingly aware of additional types of pain, nociplastic or neuropathic, that may be confounding our interpretation of the pain of the patient in front of us. Here's an example in axial spondyloarthritis conducted by a colleague who's living and working in southern Brazil. And what's noted here is that in this group of approximately 16% of patients that had concomitant fibromyalgia along with their axial spondyloarthritis, their measures of disease activity, like the Bostai score, were twice as severe as the patients who did not have concomitant fibromyalgia. And here's another study done in France in over 500 patients going on a TNF inhibitor for treatment of axial spondyloarthritis. They were administered a fibromyalgia measure known as the first FIRST measure, which showed that at baseline, 31% of them qualified for the diagnosis of fibromyalgia, which is about right, 20 to 30% of most of our rheumatology cohorts, lupus, RA, and so on. will have concomitant fibromyalgia. And as you can see, the patients that did have concomitant fibromyalgia were less likely to achieve a ASDAS low disease activity or remission response with TNF treatment. One interesting observation was that at the 3-month mark, when they were re-administered the first questionnaire, this time only 18% of them scored in the range of fibromyalgia. So it's possible that effective treatment of the underlying rheumatic disease condition may lower the central sensitization phenomenon in the patient's central nervous system. And then I'd like to, our last study I'd like to, this is my last slide, is the recently conducted UPSTAND study with upadacitinib. This is an open observational study of 581 patients being treated with upadacitinib for axial spondyloarthritis. It was conducted in Europe. And even though in this study, having a diagnosis of fibromyalgia was an exclusion criteria, nonetheless, when we actually measured using these validated questionnaires, such as the WPI, the Widespread Pain Index, and Symptom Severity Scale, we found that 49% of the patients scored high, meaning they could have been diagnosed with fibromyalgia if we were using the questionnaire results as opposed to self-report or the physician judgment. So what happened? So what happened is that during the course of the trial, in the lower right-hand graph, you can see that the patients that scored high in the orange had less pain improvement than the patients that did not score high and had very good pain improvement with upadacitinib. But nonetheless, patients did have, even with fibromyalgia, had some response. And during the course of the of observation, it was discovered that patients, the scoring on the WPI and SSS reduced significantly, just like in the previous study that I just showed you from France, suggesting that a medication such as a JAK inhibitor may have some influence in some way or another on central pain. And what we have found in clinical trials is that it seems like the JAK inhibitor class has the most quick onset and significant improvement in pain, followed by the IL-17 inhibitors, and then followed by the TNF inhibitors in this regard. So an important thing to keep in the back of our mind as we're treating our patients. So with that, I'm going to stop. I'll stop sharing.